Should we get the panel to introduce themselves?
So I'm Lisa McGurr, I'm the physiotherapy manager in St Francis Hospice, Dublin.
Hello, I'm Bernie McGreevy. I'm a physio by profession, and I'm the Community Palliative Care Lead in South Eastern Trust in Northern Ireland, and just recently joined the Department of Health in Northern Ireland as AIIHPC Cancer Services Lead.
Hello, my name is Niamh Donnelly and I'm the Occupational Therapist Manager in St Francis Hospice, Dublin.
Hello everybody, I'm Tracy Haylett. I'm an advanced practice palliative care dietitian working in the South Eastern Health and Social Care Trust in Northern Ireland.
Two microphones.
We can do a double act on the microphones. So, this was taking my photo at the same time as I'm speaking. So I'm going to start off with a question, which is very me, I know. But Bernie, I just wondered, would you be able to reflect on the different levels of palliative care rehabilitation services on offer across, is the differences across Northern Ireland? Because I know we've heard a lot about the Republic today, so.
Yes, so in Northern Ireland we're very jealous of your palliative care strategy because we haven't had one since 2010, and we've been calling for one for quite a while. I was hoping that other people from Department of Health might have been here, but we will knock on their doors anyway. So palliative care services in Northern Ireland are very hard to navigate. So I'm not quite sure how patients do it, because even as professionals we find it extremely uncoordinated. And I found it very interesting in the first presentation that nearly 25% of patients find it as an uncoordinated service. We tend to all know each other and we have really good interagency and interdisciplinary working, but the offer within the 5 different trusts in Northern Ireland is very different. So some teams have a community palliative care that has allied health professionals, so it has your 4 main physio, OT, dietetics and speech and language. Some teams have social work, some teams have nursing within that. Other teams link in with the hospice nurses as their specialist nurses. So the offer varies hugely, and it's that postcode lottery, I suppose, depending on where you live, what the offer would be. And again, that varies again in what hospice services offer for the different hospices in Northern Ireland, from an allied health professional perspective, and also then for inpatient. So there are no inpatient specialist palliative care AHP posts.
Thank you, Bernie. So, have we got any questions? Well, I hope we have some questions from the floor.
Happy to kick off a response to this question. I'm guessing that you are from a psychosocial discipline, which is fantastic. Who else in the room today is from a psychosocial discipline? So about 3, 4 maybe. So first of all, say fantastic that you are here. In response to the question about a lack of psychosocial professionals in the rehab task force, we would love to have your representation. The way that we formed that task force was by putting out a wide call, and we had no psychosocial professionals express an interest. So I think the fact that there's already 4 of you in the room today is really positive. Psychosocial professionals absolutely have a key role to play in rehabilitative palliative care. Rehabilitative palliative care is for everyone. And I have found in relation to language, working particularly with social workers, I think that you as a profession really excel on a strengths-based approach. So asset-based model where you're really identifying what those existing strengths and internal capacities that a person has are, and looking at how you can build on that. And if engaging psychosocial professionals needs the language strength-based approach to make it click, then that's the language that we should be using. So I would be really interested to hear more from those of you that are here today. What's attracted you to be at this day? What's made it click for you? How can we get this message to other psychosocial professionals to see that this is core? And as you made the point, care is absolutely key to this. Yeah, where is their role? How do we empower them alongside the person that is the patient? So there's work for us to do to evolve it, to make it everybody's business. And I think the space it needs to go needs to have each of these different discipline voices helping us understand how it can really reach its full potential.
From a Southeastern Trust perspective, we are delighted that we have just welcomed 2 social workers onto our community palliative care team. So they are roles that have been vacant for over 3 years. So we are happy to start with like a carte blanche as to how that works. So I'm sure Emma, who's actually here today, would be delighted to have a conversation about that. But the whole team completely value their input. And from having worked in rehabilitation and everything before, that aspect is crucial in all aspects of rehabilitation, not just palliative care, but I suppose has particular importance in palliative care because of that holistic assessment that our patients receive and that their significant others, whether that be their neighbour, their husband, their wife, their family, are included in what we look at and what is their person-centred goals.
I suppose, Niamh, just to echo your comment about the language and that, I suppose rehabilitative palliative care in terms of a term has only been around for so many years, and it's still evolving. It's still, I suppose, every year we're seeing, I suppose, more and more rehabilitative palliative care, and it's still very varied across all of the different services. I suppose just in terms of that language around goals, I think that's very much embedded oftentimes within our practice, and it's going to be very hard, I think, to move away from some of that language. But I suppose what we can do is try and use those terms like that, what matters to me, what matters to you, in terms of incorporating the families and the carers along with the patient and their social network. And I suppose asking those questions around what their priorities are rather than that piece around what their goals are, because as we all know, it's much easier, and Rebecca mentioned earlier on around that piece about how to use language with patients, whereas we might write in our notes a goal for a patient, asking them what their priorities are or what matters to them is a lot easier to answer for those patients, and that way we can kind of explore to them what is the meaning in what we are doing with them and working with them towards.
I have to be careful what I say here because we have a programme board meeting tomorrow. So I suppose the big challenge for me as an AHP has been getting our voice heard. And as Rebecca said beforehand, a lot of the senior posts tend to be nursing or medical. So even having representation on groups has been extremely difficult. We have battled for, and I say battled not lightly, to get our voice heard and to get a seat at that table. But it's taken a lot of networking and a lot of input from the AHPs who are so passionate about palliative care and kind of creeping our way up to get that seat. But again, we have one seat as a representation in the regional palliative care and programme board. And thankfully I have that seat. So it is a big responsibility to sit and to try and bring this forward as an agenda. And you are also battling against what people perceive your roles to be. And even people who are working in palliative care who don't actually know or maybe haven't taken the time to know what those different roles are. Just as an example, talking to a palliative care consultant, and I said about you really need an MND pathway for patients in our trust so that we get referred the bulbar diagnosis from diagnosis, that we start to see those people and their families because it's so rapidly progressive. And they were shocked that we were seeing MND patients and their palliative care consultant. So that is the sort of thing we're battling against. And they were like, are you really the people who should be seeing those? Like, well, 100%, yes. So it is getting influence, I think, is the main thing in those structures. And the fact that you have a strategy helps. And we can steal all your data and get that forward. And I think that's probably where, particularly in rehabilitation, we don't have that data to back us up because we're too busy actually seeing the patients.
I'm going to bring this down just a little bit lower. It's not the high echelons, but it would be very specifically dietetic profession. And in a different job, I had to fight every single day to try and get management to understand what a palliative care approach was, let alone any kind of rehab or anything like that. And that went on and on and on, and it was like banging my head against a brick wall. But then there was something that happened that really made me realize that what I was doing was right. And that was very, very empowering. And I have been able to take that forward, and I've built on that. But when I say for years and years, it was 16 years. That's a hang of a long time to just have to fight my corner and be asked things like, do you really think that that's your role? Do you think you should be doing it? And when you look at the broader sort of context of what palliative care is and that approach, the rehabilitative approach, etc., it was 100% my job. But there was absolutely no understanding from management. So they were trying to put me in a box and keep the lid on the box. And me being me, I kept popping out of the box, which I'm pleased to say I did, because I've now got to where I am, and it's a really good place. But it's not been easy, and I would imagine that there are other professions who've had a similar problem. And I would just encourage everybody, if you're there and you're trying to pop out of that box, just keep on popping, and it'll be okay.
I suppose I'm just going to comment in terms of, I suppose, that research piece and that evidence-based practice. I think that while there's still a limited enough evidence-based literature on rehabilitative palliative care, there's more and more every year. And I suppose just to encourage people within the room, if you're working in a rehabilitative care setting, whether you're dietetics, speech and language therapy, OT, physio, start that research project, collect that data, publish that data, and get that evidence out there and support each other along with that as well. I think that is really important to be able to prove our worth.
I have been there and around the circle many times, and I think to influence you need a multi-pronged approach. So when I was leading therapy services, remember back when I had 3 physios and nothing else, I did a lot of education, put a lot of time into helping people understand the value of the professions that we needed and didn't have. But not just talking about what the positive addition of these professions brings, but also the risk of what you lose by not having them. As a colleague at the back mentioned, speaking in monetary terms around admission avoidance, early discharge helps. And what I found was that I needed to go around things. So I made very good friends with my fundraising department in the hospice. They love a rehabilitative initiative because it's really positive. It's about enablement, quality of life. But I brought in my own funds. And that gave me a lot of flexibility, because if I had funding coming in for a rehab project, well, nobody was going to say no to that. And it meant that I could grow the service, illustrate the value, and then work to sustain that. So that's a sideways approach. Have a look for funding opportunities and go for them. It's not necessarily within your traditional role, but there's value there. And the other is a great study. It's quite old now, but it's by a colleague, Penny Wazalo, which looks at rehabilitative or palliative rehabilitation, I think it is, in UK hospices. And she identifies factors for where it was successful and where it was less successful using a stakeholder salience model. And what she found was that power and influence are key. So you can have all of the evidence, you can know it's a fantastic initiative, but unless you have that senior leadership buy-in, you are not going to get where you need it to get to. So you need to really make sure whoever your representative on the senior management team is really understands and is on board. If you don't have good representation at that level, look at how you can get yourself invited to have a voice around the table. And I think in behind this is just persistence, as you mentioned. It's Like, keep bringing the topic up and really offer it as a solution, the future solution.
I kind of echo everything that the panelists have said, and I have to confess, I too am a jack in the box, and I think Regina McQuillan would very much testify to that. I think I agree with everything everybody has said, but start small, measure, prove the worth, and just have your voice heard. I think that's the key message, and it is. I think we've all been at it for very, very many years, but I think we just have to keep at it and keep having our voices heard.
My name's Pete Burbidge. I'm working for the Department of Health in Northern Ireland, and one of the jobs I've been given as the HP lead is to develop a rehab framework for Northern Ireland. We are the only part of the UK that doesn't have a rehab framework in place, and we're significantly lacking, as some of the comments have been made up there already. We have no leadership for rehabilitation. We have no one accountable for rehabilitation, so it's really difficult to drive forward and innovate and develop services. The framework is obviously addresses all of rehabilitation, so it's very, very big. And the task has been sort of mammoth to try and get a framework that's meaningful, that has impact, that people are going to be able to pick up off the shelf and actually see what it means to them in their day-to-day roles and how it's going to improve services. There's two big key asks for Northern Ireland. That is that we have a rehabilitation lead and we establish a rehabilitation network, because all of the work that's going on here, all the things that you're doing, can all be driven forward by those two key places, those two key positions. The network will be made up of service users, of key people in influence, of key clinicians from across the board, so that we have a voice and that we are able to drive forward the rehabilitation services that we need, ultimately to meet the needs of the people of Northern Ireland in all aspects of their rehabilitation, because at the end of the day, they're the ones that are suffering because we don't have the rehabilitation services in place to meet their needs. So.
Can I just ask that palliative care is one of the case studies in your framework? In front of all of these people?
Yes, you can. I've been asking for case studies. I have numerous case studies. I do have some from cancer services, but yeah, I'm more than happy for you to submit a palliative care. And as soon as you sit on the desk next to me, Bernie, you can do that quite easily.
I'll get one to you on Monday.
Thank you.
I guess just one of the things that comes through to me in discussions through the day is that sometimes when you are challenging culture, which is essentially what we're talking about, it can feel like quite a lonely place. And some of you are here with colleagues, but some of you are here as lone representatives. And I guess some of the opportunity of today is identifying other people that think in a like-minded way. And I guess one of my questions to you is, how do you see that you can build on today? You know, what would help you? What does Ireland, Northern Ireland, Republic of Ireland need to be doing to really make this best practice for everyone? What are you going to take away?
I would like you, Rebecca, to come to our programme board and do a presentation on palliative rehabilitation. I think that would be really useful for them to hear that voice from that international strategic level.
From us in the Institute and me and my colleagues, I suppose obviously we're working with Mary and Elizabeth, supporting the position paper, and I think we're all really looking forward. And like I say, there is the opportunity to meet with Elizabeth and Mary following this, so if you're interested, please do get in touch. But looking at when we have the position paper, how do we drive that forward? I suppose not preempting what some of those recommendations might be and what the research is. I'm sure it's really interesting. But how can we take this forward? I suppose for ourselves, when we're thinking of the business plan for 2026, did I already say that? But thinking about what can we do to support that within the Institute, with the communities of practice and with other initiatives as well, because this is, for us, is kind of the start of a programme of work, and I just would like to thank the steering group, Lisa and Neve and Martina, for their support with organising today, and and I'm sure you'll be involved in steering those thoughts, Sally. Steering those thoughts going, Bernie. Got your names are written down, so how do we go forward? And so it's the start of a discussion, start of developments. So
Karen, can I just add, when we're looking at the competency framework as well, with that coming up, that might be an opportunity to look at rehabilitative competencies as well across all the professions and how we bring that through as well, so everything is all in one place. So that's just an idea.
Yeah, definitely. Because one of the commitments in the policy is to update the palliative care competency framework.
I love, Rebecca, when you finished up and your presentation earlier, you said about, doing the questionnaire from the Nursing Times around what would it be like for the All Ireland Institute to do a questionnaire across all interdisciplinaries, all disciplinaries, to see what we understand of what each one of us do, so we can grow on that and bring us closer and bring us more together to produce this working group and the future of specialist palliative care and palliative care approach. I think that would be a lovely exercise, Karen.
I'd just like to add that for a long time, we as dietitians tried to have a kind of a specialist group because there are so few specialist palliative care dietitians in Northern Ireland. And more recently, we've got a community of practice. And that has been really, really important because we are now working on something to do with nutritional assessment, because up until now, nutritional assessment is very much based on people who don't have a palliative care diagnosis, and it doesn't fit. And so we have dietitians who are, and other professions who are weighing people inappropriately and not really doing what we feel that they should be doing. And we're now going to be working on something that is going to be innovative. Now, this has taken years to get to this point, but I'm quite confident that because it's an all-island approach, we as the experts in palliative care and nutrition are going to produce something that's going to be really brilliant. And I'm very proud that it's going to come from the island of Ireland. The UK doesn't have it, the mainland, Scotland doesn't have it, Wales doesn't have it, but Ireland's going to have it. And I'm hoping that within the next year we're going to actually have something on paper. And it's just really an encouragement that you can just, something needs to click and you just get on with it and do it, and then you can present it, and it's hopefully going to be really, really good.
I'm talking as an academic, but I'm also talking as a nurse and a health economist. I know they're kind of a bit of a weird mix, but I think very much around the area that you're talking about resource, influencing policy. The thing that does make a change is about evidencing the costs, the benefits. But because your area, you're trying to really push, your rehabilitative approach, could you please build evaluation into everything that you do? And please, please try and bring some cost-benefit analysis, because I can tell you, I know there's only one study of hospice care that actually looks at the cost-benefit analysis. And the only reason I know that is because I actually examined it. So I know there is only one study currently. So I know it's not an area, you're more about practice, delivering of service, but think about partnership. And that partnership could be with an academic institution, which could provide that evidence base, so that evidence base can be that basis for you to lobby MLAs or to lobby government here in Ireland about the value, return of resources and the benefits of your service. And that should make a big difference, but just consider it.
So my name is Dee Dee. I'm a dietitian in Wicklow Hospice, and my other role that I work part-time, I actually work for the HSE Communications Division, and we're currently writing palliative care sections for the HSE website. And as a AHP, it's quite nice to be in that room. We're going to be obviously going to ask the public what they feel they should know about palliative care. And from my perspective going into it, I'm very conscious that we need to mention what palliative care does beyond end of life. I think there's a big PR problem we have anywhere when it comes to palliative care, that we are not just providing end of life care, we are providing a service that supports them to live their best. And I suppose as part of my own research maybe today, we are going out to ask the people what they should know, but maybe if the panelists want to share what they feel the public should know about palliative care from a rehabilitative perspective. Obviously any resources that we're going to be producing, we need to have that public statement as well, because we need to be reaching out to our public about what we do, because from there the votes are going to come in. You know, this is going to be the direction our politicians want to go in, and we influence by influencing the public.
I'm going to put an offer out before I pass that if we can support you in the Institute with that, we have our Voices for Care volunteer. We're already linked up. I should have known. I'm going to pass along.
So there are currently 2 offers in Northern Ireland, resources for patients or public to access. Northern Trust have a great advanced cancer toolkit that we're hoping to regionalise, and also Southern Trust. So Jared, who's just left to get a train, but I can give you his contact details, has produced, it's called The Pearls. So it's a palliative education and resource library, and there's a public facing version and there's a professions version. So they're both excellent resources, frequently updated, and have active links to all different types of information on symptom management, what palliative care is, what different roles are, and different organisations and signposting.
And actually, I should have mentioned that we will be shortly testing. We've redeveloped the Palliative Hub Adult, consulted with both our Voices for Care volunteer group, but also focus groups and a survey of interested people, health professionals and Voices for Care members. And so we'll be shortly testing the site, and then we will be launching it hopefully in late June, early July. And on there is information about palliative rehabilitation. And we have some kind of whiteboard animations that Dr. Kathy Payne, who I know Rebecca and others will know, who's now with the European Association for Palliative Care. What I would say about the Palliative Hub Adults as a wider piece, that when people see it, if you do have any comments, if you have any feedback, if you have any suggestions for how we can develop it going forward, then please do get in touch, because we're relaunching the site, but then going forwards we want to continue to improve it. So, but there is an area around palliative rehabilitation that does link to some resources. So.
I suppose just one of the other things, what do we want society to know? And I suppose palliative care, in terms of, you heard Declan earlier on, he thought, oh, this is the end for me. And I think that's kind of echoed a lot throughout society. Something that we've come up in our outpatient and day services is that piece around discharge, and patients now knowing that actually they can be discharged from palliative care services and that they can dip in and out throughout their journey. I think that's a really important message to get through to the patients and to their families and society, just around that palliative care is not just now for the end of the life care, and that we do provide services throughout and support patients throughout their journey. That's just at a very basic level. I know the others are talking about a little bit higher level stuff, but I suppose that would be the messaging and some of the videos that are on the All Ireland Institute website around that patient story piece are really valuable pieces of resources to show people inside, just to get that understanding across around. I know there's a couple around the programs and that, and patient stories are really interesting to see.
Dee, I think you'll know exactly where I'm coming from when I say what I'm going to say. But people are quite often horrified to even sit at the same table as a dietitian, and I'm just talking about the general population, let alone someone with a palliative diagnosis who has a dietitian knocking at their front door. So I think it would be a good idea to explain our role, because it's very different from perhaps somebody who's doing health promotion, and that is definitely the perception. And we do get a bit of bad press quite a lot of the time, I find.
Super. So I'm going to draw this to a close. So I'd like to say thank you so much to the panel. I really appreciate everyone speaking so honestly and candidly. I think everyone here, anyway, round of applause.